So the topic of lecture is oral manifestations of systemic diseases. Lecture outline such issues. First of all, disorders and their disorders of gastrointestinal disease and their manifestation on oral mucosa, cardiovascular diseases and endocrine disorders and their manifestations on oral cavity. Taking into account that oral cavity is a mirror that reflects many of the human body's internal secrets, some of these manifestations are specific for a certain disease. That's why it is very important to recognize them and provide correct diagnosis. And actually, it's true that mouse is a mirror to the human body. And actually, the dentist to some extent is the first doctor, the first person who can recognize and who can notice the smallest symptoms, the first initial symptoms of some systemic diseases, and is responsible to refer the patient to an appropriate doctor for further diagnosis and further planned treatment. So the oral symptoms are not enough to provide a definitive diagnosis of their own, but can be a significant factor in pointing a clinician toward a positive diagnosis and prompt them to investigate for the possible source of distress. In some cases, oral signs may appear in the absence of obvious abnormalities, and actually that is the key of this diagram, that sometimes oral manifestations are typical for that diseases that it seems to patient that he don't have this disease, but really he have it due to oral symptoms of it. For example, let's start from the gastrointestinal diseases. We have such disorders that are typically manifested on the oral cavity. It is gastroesophageal reflux and such eating disorders as bulimia and anorexia. Gastroesophageal reflux would be visible in oral mucosa in the form of dental erosions, and patient would feel the symptoms of xerostomia and constant water brush, burning sensations, palatal erythema and halitosis. In the case of bulimia and anorexia, as well, xerostomia is typical, dental erosions, sialoadenosis, and dental caries. On this picture, you see the patient with gastroesophageal reflux and erosions of the palatal aspect of the anterior teeth. Actually, chronic vomiting of gastric acid contents due to such causes as hypertrophic pyloric stenosis can lead to erosion of the palatal aspect of the anterior teeth. And this type of erosion is important diagnostic sign of self-induced vomiting in bulimia patients. Pay attention to this diagram here as well. You see erosion on the palatal aspect of the anterior teeth. Erosion is typical. Basically, erosions to the patients who have bulimia would be on the palatal surface of the teeth. And for opposite, erosions on the buccal surface of the teeth is typical for those who have exogenous acid intake. For example, such occupation as wine tasters. They constantly rinse their mouths with wine. It's acid, of course, acidic solution, and they have erosion on the palatal, on the buccal surfaces of the teeth. Anorexia and bulimia, such psychiatric disorders as well, can be presented in oral cavity with dental erosions. And the oral manifestations include erosion, traumatized oral mucosa, and pharynx. Of course, dry mouth would be in such patients, caries, numerous cavities, so-called multiple caries, periodontal disease, and soft tissue lesions. Here you have the erosion. Visible dentine enamel is almost worn away and dentine is visible. And pay attention to this diagram. Even yellowish spot of dentine here you can see. Such unattractive appearance of teeth. Self-induced vomiting may cause trauma to the soft palate and pharynx. Soft tissue lesions such as angular cheilitis, candidosis, glossitis, and oral mucosal ulcerations may also occur. But the reason for them can be as well nutritional deficiencies, not only anorexia or bulimia nervosa. Another disease of gastrointestinal tract is Crohn's disease. It is a chronic condition that is characterized by severe inflammation of the gastrointestinal tract. Swelled up oral mucosa, which may have the appearance of cobblestone, along with inflammation of gingiva, are the pathognomic oral manifestation of the Crohn's disease. Pay attention to this buccal mucosa, this typical manifestation of cobblestone. And on this diagram, you see the lip swelling with vertical fissures. These fissures result in ulcerations. For such a group of patients, midline fissure as well is typical typical disorder, and actually Crohn's disease can manifest with a chronic midline fissure. This midline fissure is dangerous because it's considered to be precancerous lesion, and if not treated, due to constant presence, it is chronic midline fissure. Any chronic ulcerations lead to cancer. It's necessary to keep in mind and always be aware of that. Pay attention to this diagram. Here it's shown Crohn patient with a Crohn disease, actually 16-year-old female, presented on these diagrams. Swollen gum mucosa, red gum mucosa, and here is present angular cheilitis. Ulcerative colitis. As a result of this disease, patients can manifest with piostomatitis vegetans. It's a typical manifestation for this disorder. And actually, piostomatitis vegetans is a chronic mucocutaneous ulcerative disorder that consists of multiple miliary white or yellow pustules or papules with an erythematous and edematous mucosal base. Pustules may rupture and combine together, forming snail track ulcers. So this is the very clearly visible representation of this piostomatitis vegetans due to ulcerative colitis. Celiac disease. So it is a chronic autoimmune disorder of the small intestine that is triggered by the ingestion of gluten. It appears in genetically predisposed patients. And the main oral signs are angular cheilitis, glossitis, depapulated tongue, and dry mouth. Ulcers, here you have the ulcer, are the most common type of oral lesions that presented in a papular or erosive form, generally with an erythematous margin. And of course, enamel hypoplasia is visible, is typical for these patients. And here you have this whitish spotted type of hypoplasia, and here the ulcer present on the gum mucosa. Chronic recurrent aphthous stomatitis. Another manifestation that can be observed in the oral cavity, and possibly it is connected with gastrointestinal disorders, with a chronic inflammation of gastrointestinal tract. So previously after were known as a dyspeptic ulcer, but are only rarely associated with gastrointestinal disease. And any association is usually because of a deficiency, particularly of vitamin B12 or folate acid, secondary to malabsorption, of course. An association with celiac disease, sometimes asymptomatic, has been found in approximately 5% of cases. But a secondary hematinic deficiency, particularly folate deficiency, is probably the cause. So necessary to keep this in mind, this information, and just pay attention to this presentation of APHTA. Oval or roundish defect of mucosa that is encircled by a red line of inflammation, clearly visible border of inflammation, red line, and covered by a fibrinous coating. These after are painful and cause a problem during communication, during mastication. And that's why to such patients the only possible dental management could be symptomatic by applying local analgesic solutions topically, for example, lidocaine in spray or benzocaine in gel. Prescribed for them antiseptic mouthwashes such as chlorhexidine. As well, can be recommended such antiseptic as Hivalex. And on the stage of healing to the mucosa can be applied keratoplastic medicaments. They are different types of oiled vitamins. It could be A or E, but basically A, or rosehip oil or sea buckthorn oil. That are the medicaments and dental management of such disorder as APHTA in oral cavities, of symptomatic treatment. Jaundice, it has such oral manifestation. First of all, sclera is of yellowish color, and in general skin of such patients would be yellowish, with a yellowish tint. In the oral mucosa would be discoloration that are frequently visible on the hard palate, actually in the border between hard and soft palate in this line. It would be yellowish color, or possibly with a brownish yellowish dots. That is the symptoms, oral symptoms of jaundice. Prior to talk about cardiovascular disease, I want to stress your attention of how to provide dental management of patients with ulcerations or those who present angular cheilitis as a result of gastrointestinal disorders. As I said before, symptomatic treatment, antiseptic, basically it is antiseptic treatment of oral cavity with chlorhexidine mouthwashes. then applying topical analgesia if necessary, if these lesions are painful, and can be applied artificial lysozyme as a mouthwash, few times a day, of course, and at the stage of healing, keratoplastic medicaments. So that is the main steps in dental management of this of the patients who have ulcerations on the oral mucosa. Because dentist cannot treat the general disease, it can only help the patient with the dental symptoms. And so right now it is cardiovascular diseases. As well, they are manifested in oral cavity and actually can be very clearly visible. And the classical risk factors for cardiovascular disease, it is hypertension, hypercholesterolemia, and cigarette smoking. The most widespread cardiovascular disorder is hypertension. Actually, hypertension don't have its typical manifestation on oral mucosa. But on the oral mucosa can be present lesions as a result of medicament intake as a treatment, as a result of treatment of hypertension. Actually, these antihypertensive drugs cause side effects. And actually, these side effects are as follows: xerostomia, gingival overgrowth, salivary gland swelling or pain, lichenoid drug reactions, erythema multiforme, taste sense alterations, and paresthesia. That are the main symptoms of side effects of antihypertensive drugs. So here I have collected different groups of medicaments that are usually taken as a therapy of hypertension, and they are as follows. So diuretics may cause oral dryness. Adrenergic inhibitors can cause oral dryness and ulcerations. Calcium antagonists usually give rise to gingival overgrowth. Angiotensin-converting enzyme inhibitors cause loss of taste and lichenoid reactions of the oral mucosa. Cardiovascular diseases in oral cavity manifested with such symptoms. First of all, it's from the site of periodontal tissues, different stages of periodontal disease, lichenoid stomatitis, xerostomia, gingival hyperplasia, hemorrhagic complications, and erythema multiforme. So periodontal disease. Actually, there is a clear connection between periodontal disease and cardiovascular disease, but this idea has two points of view, and no, it's hard to decide for researchers whether the periodontal disease developed as a result of cardiovascular disease or cardiovascular disease progress, exacerbate as a result of chronic periodontal disease and chronic inflammation in gums and chronic bacteremia as a result of this disease. So clear connection is obvious with periodontal disease and cardiovascular disorders. According to scientific research, it is stated that cardiovascular patients with active periodontal disease are 1.5 times more likely to experience a fatal cardiovascular event due to increased inflammation and increased bacteremia risk. And yes, and on this diagram is clearly depicted. Like you can see this connection with periodontitis and heart disease. Lichenoid stomatitis, another manifestation of cardiovascular disorders on oral cavity. So, lichenoid reaction. Here you have the buccal mucosa and the tongue mucosa, and pay attention to the specific network of Whithem. Lichenoid reaction usually is presented with whitish patches or papules on mucosa, and typical localization: buccal mucosa, retromolar area, and dorsal of the tongue. The term lichenoid reaction actually refers to the lesion similar or identical histopathologically and clinically to the lesion planus. But we cannot state it is lesion planus because lesion planus has another reason. But a reaction is similar, and actually it is similar not only clinically but also with a microscope. So here you have the lichenoid reaction on the dorsal tongue of the female as a result of intake of furosemide. Pay attention to these ulcerations. And size of tongue, it's a little bit increased with imprints of tooth. Here you have. So xerostomia as well is one of the symptoms of cardiovascular disorders. And not actually as a cardiovascular disorder, but as a side effect to medicament intake due to treatment of this disease, for example, hypertension. Xerostomia can be a symptom of few more diseases, and they are as follows: Sjogren's syndrome, autoimmune disease, HIV/AIDS, Alzheimer's disease, diabetes, anemia, rheumatoid arthritis, Parkinson's disease, mumps, stroke. As well, xerostomia can be symptom of a tobacco use, as a nerve damage, or even dehydration. Xerostomia or dry mouth, it is a synonym. So such medicaments can cause the adverse effect on oral mucosa and provide xerostomia. These medicaments are diuretics, adrenergic blockers, B1 adrenergic blockers, centrally acting sympathetic agonist, and synergistic effect. So synergistic effect with other medicaments is obvious to develop the dry mouth. Together with xerostomia can be present angular cheilitis, these cracks in the corners of the mouth. And actually it is can be explained in this way, that there is no appropriate amount of saliva, and as you know, saliva provides antibacterial effect and kills pathogenic microorganisms due to the presence of lysozyme or histatins in the oral cavity. So if there is a lack of saliva, it's obvious that such lesions as angular cheilitis can develop. Symptom of gingival hyperplasia, typically due to medicament intake, a long medicament intake, a long time. Such medicaments as calcium channel blockers, usually cause gingival enlargement. Pay attention. Hyperplasia of gums. The gums are firm and during palpation painless. But due to the presence of plaque, especially if there is a retention point, such as problem with occlusion, as in this case, extra retentive points for plaque collection, such a symptom can be accompanied by inflammation, and as a result can be pain. How to manage? Of course, if such symptom develop, it's necessary to contact with a dentist, with a doctor who prescribe these medicaments and try to change the medicaments to other possible in the case of a certain disease. Look at these pictures. Such hyperplastic gums. And here as well. Like epulis it looks like, but it's hyperplasia actually. That's why when such conditions, such manifestation is visible in the oral cavity, dentists should always collect appropriate anamnesis of patient's life and patient's disease. And only in this case can be set a correct diagnosis. That is the key fact, for sure. Erythema multiforme. On the tongue and on the lip. The main element of lesion in the erythema multiforme is spots, red spots, vesicles that are ruptured, and together with ruptured, after the vesicle were ruptured, there would be exudate. It could be blood, hemorrhagic exudate or yellowish exudate. That's why these three elemental lesions are present at the same time on the mucosa. So spots, red spot, erythema, vesicles, and ruptured vesicles with crusts and hemorrhagic crust scales even. So you won't misdiagnose if you see these three elements. For sure it is erythema multiforme. And calcium channel blockers intake lead to erythema multiforme. In the patients who have cardiovascular disease. Erythema multiforme can develop itself as autoimmune disorder, of course. But in those patients who have medicament intake of as calcium channel blockers, it can develop as an adverse effect to the medicament intake. So oral manifestations of anticoagulant therapy. Actually, oral manifestations of anticoagulant therapy is rare, but nevertheless it's available. So even a minor trauma to the oral mucosa may cause various hemorrhagic lesions. And these hemorrhagic lesions are as follows: petechia, purpura, ecchymosis, hemorrhagic bulla, and hematoma. What is petechia? Petechia, it is a small small hemorrhage of 2 millimeters and ecchymosis less than 1 centimeter. Purpura. Here you have the purpura on the tongue, bigger than 2 millimeters and can be a little bit bigger than 1 centimeter. So here it is a purpura and hemorrhagic bulla. Here you have on the retromolar area. And now we move successfully to endocrine system. Endocrine pathology include such diseases. The most typical manifestation that can be visible in oral cavity and that dentists face during routine practice is the manifestation of diabetes mellitus. And actually, the task of dentist to recognize and to help the patient, of course, symptomatically. Actually, diabetes is one of the most common systemic disorder, chronic systemic disorder, that dentists face in a routine dental practice. And this is characterized by hyperglycemia due to either a deficiency of insulin secretion or resistance to the action of insulin, or both. Chronic hyperglycemia leads to different complications in various regions of the body, including the oral cavity. So blood glucose control is very critical to such patients. Diabetes mellitus can be type 1 and type 2. Type 1 diabetes mellitus is usually diagnosed, and many patients are diagnosed when they are age of 20. In this disease, the body makes little or no insulin, and daily injections of insulin are needed for such patients. The exact cause is unknown. Genetics, viruses, and autoimmune problems may play a role in development of type 1 diabetes. Type 2 diabetes is far more common than type 1, and it makes up most of diabetes cases. It usually occurs in adulthood, but young people are increasingly being diagnosed with this disease. The pancreas does not make enough insulin to keep blood glucose levels normal, and often because the body does not respond well to insulin. Many people with type 2 diabetes do not know they have it at all. And actually, this is a serious problem. And type 2 diabetes is becoming more common due to increasing obesity and failure to exercise. So it's a lifestyle disorder that increase in incidence nowadays. Symptoms of diabetes general. So it's this diagram presents the general symptoms of diabetes of type 1. Such symptoms: we have patients have fatigue, increased thirst, increased urination, nausea, vomiting, weight loss in spite of increased appetite. In the case of type 2, symptoms would be such: problem with vision, fatigue, increased appetite, increased thirst, and increased urination. It is general symptoms. Once again, I should stress on this. And here you have the oral manifestations of diabetes. They are as follows. Candidiasis, first of all, dental caries, due to the problem with salivary dysfunction, salivary gland dysfunction. As a result of lack of saliva, periodontal disease can develop, and microorganisms such as opportunistic infection as Candida can progress and persist in oral cavity of the diabetic patients. Xerostomia due to dysfunction of salivary glands, and burning mouth syndrome. Saliva plays as well a role in providing immune function, protecting the oral cavity from any pathogens. And for that reason, oral mucosal lesions are typical to the patients who have diabetes. And actually, such classical pathophysiologic features of diabetes mellitus that include immune dysregulation, vasculopathy, and neuropathy plays great role in development of these oral manifestations. Of course, these symptoms negatively influence the patient's quality of life and disturbs him. Nevertheless, the task of the dentist to recognize if the patient these symptoms, if the patient is not sure about his diabetic status, dentist should refer the patient to a special doctor endocrinologist, and of course there would be provided appropriate diagnostic and somehow to correct endocrine disorder, diabetes mellitus. Dental caries. Numerous dental caries, rampant, we may say, due to endocrine disorder. Pay attention to this diagram. Rampant caries, actually, it is that type of caries where few surfaces of teeth are involved and almost all dentition is involved in the pathological process. So here you have this diagram that will show you that saliva actually plays a role, pH of saliva, appropriate amount of saliva, flow rate of saliva, and buffering capacity. All of that influence the caries development, and it's for sure if saliva is in lack, so numerous caries would manifest in the patients who have diabetes mellitus. Together with caries, dental caries, patients with diabetes mellitus could be presented with periodontal disease. Periodontitis. What is periodontitis? It is a chronic inflammation that results in a progressive destruction of the supporting tissue of the teeth, as well as a pocket formation, gum recession, or both. And this may lead to tooth loss due to damage of the alveolar bone as a result. Necessary to stress on that fact that periodontitis develop due to microangiopathy. That is the pathogenic mechanism of periodontitis development. Pay attention to this diagram. Here you have the patient with periodontal disease, diabetic patient. Gum recession, inflammation, possibly there is a pocket, gum pocket during taken by probe. Here you have on this X-ray the loss of bone tissue. Okay, vertical, aggressive loss of bone tissue. People who have diabetes are at high risk for oral health problems, and they are such gingivitis and periodontitis. And people with diabetes have great risk with gum disease because they are generally more susceptible to bacterial infection and have a decreased ability to fight bacteria that invade the gums. So here you have clinical manifestation of periodontitis, chronic generalized periodontitis. On this picture, gingivitis, hyperplasia of gums, false pocket presence, great deposition of calculus, soft and hard dental calculus, and of course inflammation of gums due to this of the calculus, and plus due to vasospasy. Because it's the main pathognomic symptom in diabetes, microangiopathy. And here, as well, patient with diabetes mellitus, loss of teeth, recession, numerous cavities, in particular root caries is available. During touching by probe, such gum tissues can bleed, and actually the bleeding will be pronounced. Would be spacing between teeth and loosening of the teeth. So here you have so just look at this picture and try to analyze, to memorize this manifestation of diabetes mellitus in oral cavity from the point of view of periodontitis, chronic generalized. In addition to periodontitis and dental caries, other oral conditions commonly occur in the patients with diabetes mellitus, and these include fungal infections, salivary gland dysfunction, neuropathy, and mucosal disorders. These disorders are related to chronic salivary hypofunction and to the generalized immune dysfunction seen in diabetic patients. So first of all, xerostomia. Yes, this symptom accompanies different diseases, and diabetes is one of them. So xerostomia is reported in 40–80% of cases of patients who have diabetes, and this is related to decreased salivary flow rates. The function of saliva normally to protect the oral mucosa from different types of injuries and to moisturize it, to facilitate comfortable communication, swallowing, protect from caries, kills microorganisms. So that are the functions of saliva: lubrication, cleansing, pH buffering, and antimicrobial. And if there is xerostomia, of course, these functions are not maintained. That's why the patient suffers from different problems of oral cavity that accompany xerostomia. And the mechanism by which salivary flow is affected in diabetic patients is thought to be the result of autonomic nerve dysfunction or microvascular changes that diminish the ability of salivary gland to respond to neural or hormonal stimulation. So here you have the dry mouth of the diabetic patient, and salivary gland hypofunction and periodontal disease in patient with second type of diabetes mellitus, so periodontal disease. Burning mouth syndrome. So a burning sensation of the oral soft tissues is a frequent complaint in diabetic patients, making diabetes the systemic condition most frequently associated with this symptom. Although oral mucosa conditions such as the candida infections, lesion planus, and dryness can cause burning sensations in diabetic patients. A neuropathic basis is supported by observations that the burning sensations in diabetic patients are frequently accompanied by changes in taste, dysgeusia, or other sensory distortions. Additionally, patients with peripheral diabetic neuropathy are more likely to have burning sensations in oral tissues than those without peripheral neuropathy. Pay attention to this patients with xerostomia and dry mouth, fissured, cracked tongue, angular cheilitis. The next in the incidence of diabetes mellitus manifestation is tongue abnormalities. So such a disorder as bold tongue, pay attention, due to atrophy of papilla. And actually this complete patchy atrophy leads to such appearance of bold tongue. Together with bold tongue on this picture is present angular cheilitis. Here you have. It's redness or fissuring of the corners of the mouth that involves the junction of the mucosa and skin, and may also represent a form of candidiasis. So in these sites can be attached candida microorganisms and would be candidiasis. The fissuring may be the result of a chronic low salivary flow rate, which alters the environment in the oral cavity such that slow healings of tissues are more easily traumatized than in non-diabetic patients. Such symptoms as benign migratory glossitis and benign rhomboid glossitis can manifest in the patients with diabetes mellitus. And actually benign migratory glossitis, here you have some papilla are atrophied and some are enlarged. It gives this pattern of geographical tongue. So focal atrophy of the papilla gives this irregular pattern. And what is important to note that from in a time these sites of atrophy migrates. That's why it is called migratory glossitis. This condition is not caused by a candida infection, but is characterized as inflammation and may also be associated with similar symptoms of pain, itching and burning of the mucosa. Of course, if there is a atrophy, for sure there would be itching. Median rhomboid glossitis. So it's a unique condition, here you have, in which an atrophic bold spot is located at the midline of the posterior surface of the tongue, anterior to the V-shaped circumvallator papilla. It is called median rhomboid glossitis. It is commonly smooth and flat, but may be depressed or have a lobular to papillary surface. It is recognized manifestation of chronic candidiasis of the oral mucosa. So, oral candidiasis. Once again, everything is connected with saliva and salivary gland dysfunction. So, due to low salivary flow rates, saliva cannot provide appropriate protective coating for the oral mucosa. That's why microorganisms that under normal condition won't progress, in this condition progress and persist and manifest. And actually this is oral candidiasis. Here you have this Candida albicans and its manifestation on the tongue, on the throat. Here you have the throat. Tak? Lack of adequate saliva actually leads to an increased risk of oral fungi and increased caries and difficulty with maintaining oral hygiene, as well as a decrease in quality of life because of discomfort from eating, swallowing or talking. And these key points of oral candidiasis, first of all, fungal infection progress due to the increased levels of hyperglycemia. Salivary dysfunction compromise immune function of oral cavity, Salivary hyperglycemia provide substrate for fungal growth. So these are the key facts about oral candidiasis, why it develops in the patients who have diabetes mellitus. Lichen planus as a symptom of diabetes mellitus. So lesion planus, typical manifestation, usually it is symmetrical lesions on both sides of oral cavity, left and right. If it goes above tongue, it is usually symmetrical on both borders of the tongue. So it is a wide areas of the mucosa that do not wipe off. It is lesion planus. It's a hyperkeratinization, presented as a white papules. And typical lacy or patch-like pattern. It was introduced, this lesion planus was introduced by Whitham, and it is called Whitham network, such scientists, such dentists. Wow. However, here I should stress, however, similar mucosal changes called lichenoid drug reactions occur as an adverse side effect to medications that diabetic patients are commonly prescribed. Nevertheless, lichen planus or lichenoid reactions may be symptomatic with pain, burning sensation, and sensitivity to acidic foods. Other diseases of endocrine system, hypoparathyroidism. These diseases are manifested in this way. Hyperparathyroidism would be visible on the oral mucosa in these brown spots, brown tumors on the gum mucosa. And gigantism acromegaly is manifested as spaced teeth, mandibular prognathis, macroglossia, and megadontia. Such disorder as Cushing syndrome has such oral signs: fatty tissue deposition, moon face, osteoporosis, pathological fractures of the mandible, maxilla, or alveolar bone, delayed healing of fractures, and also soft tissue injuries. Addison's disease have such symptoms: bronzing, hyperpigmentation of the skin and oral mucosa. Here you have on the gingival area and on the buccal mucosa. So it don't present to patients any problem, just this is a criteria for diagnosis. In conclusion, I want to say that very often oral manifestations would be the most preliminary sign of a systemic pathology. Numerous systemic pathologies may point to common oral manifestations, or any specific oral manifestations may be associated with a particular disease. An accurate and timely diagnosis by the dentist can assist the patient in identifying the underlying pathology. Hence, a dentist must be well equipped, both clinically and academically, to be able to diagnose this pathology. So, in this lecture, I used such information from such books, and propose to you as well to enrich yourself and to go deep in this topic, look through these books. Possibly it would be effective for you. So, Oral Science of Systemic Disease, Springer, Oral Pathology, Coulson's Essentials of Oral Pathology and Oral Medicine, and Oral Manifestations of Systemic Disease. So thank you for attention and good luck.
Thank you very much, ma'am.
Thank you.